Hi, we're Video 2, and this is Biological Disasters. In 2009, a large H1N1 pandemic broke out in the U.S. This biological outbreak came from a combination of influenza viruses that had not yet been identified. Although it was initially thought to be spread only by pigs, it was apparent that transmission was occurring between humans after they had some kind of exposure to the infected pigs. The number of infections grew exponentially as more people came into contact with infected individuals. The CDC took the initial role in identifying the new influenza virus and proceeded to investigate. They began by contacting local and state health agencies as well as animal officials because the disease began by exposure to pigs. The case was reported to the International Health Regulations, IHR, Pan American Health Organization, PAHO, and the World Health Organization, WHO. The CDC takes the lead when it comes to bioagent exposure, like that of the 2009 H1N1 pandemic. They work closely with local and state health agencies to monitor the situation in regards to the H1N1 pandemic. They base their response on the epidemiology of the situation by tracing people who would have come into contact with the infected patients. Although the first two patients had some contact with pigs, the epidemiologist within the CDC determined that transmission of this H1N1 virus had been spread through human-to-human contact. In this response method, the CDC had the various states that had experienced a case of H1N1 to send a sample of the specimen in order to produce a virus that they could create a vaccination from. Once the CDC had manufactured a vaccination, they initiated their Emergency Operations Center, EOC. They did this in order to communicate to the other public health agencies about the outbreak and create the required groups through the National Incident Management System, NIMS. Each team had a specific job such as surveillance, laboratory assignments to investigate the disease further and create vaccinations, monitor multi-state cases, etc. To help coordinate these efforts, the federal government implemented their National Response Plan, NRP. This plan outlines specific roles for sector-specific responsibilities, as well as provides effective coordination between the federal, state, and local authorities. In the event of a national disaster, the various affiliated agencies are able to construct an organized coalition by following the framework laid out in this National Response Plan. The Secretary of Homeland Security is responsible for managing the communications, supplies, and reporting requirements between federal, state, and local governments. After the WHO declared the H1N1 outbreak as a national concern, the federal government purchased 50 million treatment courses of antiviral drugs for the SNS. The Incident Command System during the H1N1 outbreak played a very important role in managing local cases. During an outbreak like the H1N1 pandemic, many local medical centers can experience a surge of calls associated with worries about experiencing symptoms associated with the virus at hand, as well as an increase in walk-ins. The ICS is mainly known for facilitating the integration of all emergency systems, as well as managing response under an incident commander. The incident commander will assign general staff with designated responsibilities to ensure that all areas of outbreak response are covered. The logistics of the ICS during an outbreak include monitoring international travel, purchasing medical supplies, local transportation, maintaining services and facilities, and staffing the EOC. The operations section of the EOC is in charge of managing the teams involved in managing the coalition of agencies involved in the response. The communication between federal, state, and local governments and between the associated medical centers was a strength of our response to the 2009 epidemic. By keeping the information regarding the disease updated consistently, it was easy for the federal, state, and local agencies to make accommodations for their infected populations. Another key strength in identifying the H1N1 pandemic was the use of new technology, which made it much easier for the CDC to identify the drugs and begin working on a vaccination. There were a few lessons learned during this outbreak. It was the first time that the newly implemented IHR had been activated. In fact, some states still did not have time to reach the requirements listed within before the pandemic hit, and were not well suited to deal with the virus. Another problem faced by the WHO was their lack of funding and their inability to monitor such a wide-scale pandemic, which reached foreign countries in some cases. The WHO often does not have this budget to fund certain medical facilities, staffing, or purchase supplies needed during a national emergency. And the takeaways from this disaster: there are ways to improve for a future case similar to the H1N1 outbreak. When it comes to the IHR, proper training and briefing for the states in regards to the requirements needed in case of an emergency can be implemented to improve the readiness of the nation. Funding for the WHO could be increased, which could provide them with more options in regards to sending out supplies and staffing. Better funding and more technological advancements will lead to better antiviral agents, improving influenza vaccines, and greater and faster production of the vaccines.